Thank you very much to the organisers for the opportunity to talk about PARP inhibitors in adjuvant therapy for germline BRCA1 to mutation-associated breast cancer, and some of the questions that have arisen since the publication and presentation of the Olympia trial result. This is my major relevant disclosure. So the effect of PARP inhibitors in targeting homologous recombination deficient cancers is largely driven by the fact that most PARP inhibitors are type 1 PARP inhibitors that both inhibit the enzyme PARP, but also lead to its retention and trapping of PARP1 on DNA in a way that arrests or stalls DNA replication forks and requires homologous recombination for repair. Where cells have this functioning, they can survive, but where cancer cells are deficient in homologous recombination, they have ineffective or inaccurate repair, develop genome instability and cell death. And this is not so much the case for type 3 PARP inhibitors that inhibit the enzyme but don't cause so much in the way of trapping. Now, some years ago, in collaborations between preclinical scientists and clinician scientists, we took this through preclinical proof of concept in ES cells and mouse systems through into the design of phase 1 and phase 2 clinical trials in germline BRCA mutation selected groups of patients with initially breast and ovarian cancer, and showed that in heavily pretreated scenarios that single agent PARP inhibitors could have a therapeutic effect with modest toxicity by exploiting this synthetic lethal principle of targeting a loss, a weakness in the cancer cell that was not present in the normal cells of normal tissues. And so very soon after that, a partnership that became the Olympia trial, an academic and industry partnership set about asking, would it be possible to test this synthetic lethal principle with single agent therapy in those with BRCA mutations and high recurrence risk in an early breast cancer setting, despite best standard treatments, including chemotherapy. And in the meantime, trials were testing these potent type 1 PARP inhibitors against standard of care chemotherapy in metastatic or advanced disease with a selection biomarker of germline mutation in those with HER2 negative breast cancer and prior treatment with best standard anthracycline taxane regimens and standard of care endocrine therapy. And those trials reported and led to the approval of both olaparib and talazoparib type 1 PARP inhibitors with a selection biomarker of BRCA mutation, and the licensing of drugs in those indications. Now, the Olympia trial began in 2014 and recruited patients based on either a local genetic test or central screening detecting germline pathogenic or likely pathogenic BRCA1 or 2 mutation in the context of HER2 negative breast cancer, hormone receptor positive or triple negative, and stage 2 or 3 disease, or those with lack of pathological complete response following neoadjuvant chemotherapy. And this was to ensure that there were adequate levels of risk to take the step of testing this new treatment strategy in an ethically appropriate way. And these two clinical contexts, prior neoadjuvant chemotherapy, prior adjuvant chemotherapy, had slightly different stage criteria for recruitment of patients with triple negative disease or hormone receptor positive disease in order to try to estimate similar levels of risk. In fact, I think they probably were higher risk in the hormone receptor positive state. They're listed here. And all patients needed to have had more than 6 cycles of chemotherapy, placebo-controlled double-blind and stratified randomization by the receptor status, the adjuvant or neoadjuvant context of therapy, and whether or not a platinum had been used in the chemotherapy regimen, because there is an interaction between platinums and sensitivity in a BRCA deficient context. primary endpoint IDFS, but very important secondary endpoints of DDFS and overall survival that we'll particularly discuss. And the statistical analysis plan targeted a hazard ratio of 0.7 and planned that the interim analysis would be triggered only when a certain number of events had happened in the mature cohort, so that there was going to be a mature data set that had contributed events, sufficient events to the interim analysis. An IDFS superiority boundary was recommended to the IDMC in the protocol of less than 0.005, and it was recommended that any hazard ratio that the target hazard ratio, if it met this statistical bar, should also be supported by the degree of effect in the mature population of patients. But if significant, that one could then go on and test distant disease-free survival and overall survival with a multiple testing procedure that conserved alpha or statistical power for future analyses. Now, these have previously been presented, and I'm just focusing here on the fact that both BRCA1 and 2 mutation carriers were recruited to the trial. There was some excess of BRCA1 mutation carriers compared to BRCA2, and this was largely because the trial recruited more patients with triple negative breast cancer, more associated with BRCA1, than hormone receptor positive breast cancer. And this was largely because of that requirement for higher stage or higher residual disease in the hormone receptor positive population of patients. Equal use of adjuvant or neoadjuvant prior chemotherapy context, and nearly all had had anthracyclines and taxanes. And this is the main study result for the intention to treat analysis of IDFS, and you'll see a highly statistically significant hazard ratio of 0.58, p less than 0.001, and a difference in 3-year rate of 8.8%, curves separating early, and the majority of those IDFS events occurring as a result of distant recurrence events, although all forms of IDFS event were numerically lower in the olaparib arm than in placebo. So I mentioned that there was a requirement to look in the more mature population here with a median follow-up of 3.5 years rather than 2.5 years to see an equivalent level of effect for the hazard ratio. And indeed there was, with a hazard ratio of 0.61 and a difference of 8.6%. So that gave the IDMC confidence that this was a durable phenomena against the primary endpoint. The protocol then suggested that if this statistical bar had been met, that DDFS and OS could then be tested, and DDFS had a bar of less than 0.005, after which OS could be tested if one went down this arm of the procedure, but to call significance and yet conserve alpha for the necessary future analysis at more mature time points, it would have a very rigid statistical bar. So this is the distant disease-free survival analysis. Again, showing a highly statistically significant hazard ratio of 0.57, difference at 3 years in rate of 7.1%, and curves again separating early. And one could then go on and test overall survival. And here you see that the hazard ratio is 0.68, still around the level that we were targeting of 0.7 for the primary endpoint. But the p-value is 0.02. So given that we're saving alpha for future analyses not yet conducted, to call at this point significance would have required a p-value of less than 0.01, which is not met, and we don't call a significant OS at this very, very early time point of follow-up time point of 2.5 years. Adverse events of more than 10% is showing some excess of nausea and vomiting and fatigue, and also bone marrow effects on anemia, neutropenia, and leukopenia. But these are mainly grade 1 and 2, and modest toxicity therefore. The grade 3 adverse events at more than 10% were really anemia at 9%, neutropenia and leukopenia and a small excess of grade 3, greater than or equal to grade 3 fatigue in the olaparib arm. More significant adverse events listed here. SAEs were actually very similar between the two arms. No evidence of an excess of MDS and AML, which is adverse event of special interest, and no evidence of an increase in any other primary malignancy, in fact, numerically less, which is going to be an interesting thing looking at going forward, particularly in the BRCA-associated malignancies. Adverse events leading to permanent discontinuation, about 10%, so that's an excess of about 5% over the placebo arm. Very importantly, global effects on quality of life score, and this was only a secondary endpoint for our PRO analysis, did not show that olaparib adversely affected the gradual improvement in global quality of life score after the completion of either context of chemotherapy. And this is going to be much more extensively presented in the new data that Dr. Patty Gantz will present on Friday of the PRO analyses. So guidelines have already changed from ASCO, NCCN and St. Gallen based on these data, although the drug, I have to point out, is not approved in this adjuvant therapy indication as yet. And I think those guidelines changes by the guideline groups were influenced by effects not just on the primary endpoint, but on this crucial distant disease-free survival endpoint that was highly statistically significant and achieved with manageable toxicity, modest and manageable toxicity. Now, quite a lot of attention paid to subgroup analyses, and the steering group do feel quite strongly that one needs to point out this is very early follow-up with few events in any subgroup. And so subgroup analyses are really very underpowered and shouldn't really influence any different interpretation within any subgroup from the main effect that is adequately powered in the ITT overall population. And so I think the most appropriate way it's considered to look at subgroup analyses is really to look at a test of heterogeneity, and there is no statistical evidence of heterogeneity between any subgroup and the overall ITT IDFS effect. And so although people's eyes are drawn to the fact that prior platinum and hormone receptor positive status have error bars that, have confidence intervals that cross the zero effect line, the dotted line here, actually the correct way of looking at this, as recommended and published by Jack Kuzik, is to look at whether those confidence intervals cross the solid red line here of the main treatment effect hazard ratio point estimate in the ITT population for IDFS, and they all do, which means that you have no confidence that the result in the subgroup is different from the main trial result, and any other interpretation is probably flawed. So there do remain a number of questions that arise from these data and are still to be addressed. And one people have discussed is, do PARP inhibitors prevent BRCA-associated new malignancies? Well, Olympia remains blinded to treatment allocation, and secondary prevention endpoints are hypotheses, or effects on these are hypotheses in the trial and will continue to be followed. But this is going to take more time. The result will, I think, be very important for the idea of secondary prevention and possibly even primary prevention studies with PARP inhibitors. Could PARP inhibitors enhance neoadjuvant chemotherapy effects and improve yet further outcomes in high-risk patients, or perhaps be used as single agents to de-escalate in lower risk groups of patients? Brightness is a study which asked the question, could you add the weak PARP inhibitor, type 3 PARP inhibitor veliparib to carboplatin in a standard neoadjuvant regimen for triple-negative breast cancer? And this wasn't just in mutation carriers, and this has reported its secondary endpoint EFS result recently at ESMO. And here you can see that a very interesting result, which showed that in the broad triple-negative population, stage 2 and 3 breast cancer, that platinum added benefit, but that veliparib on top of platinum did not add further benefit in terms of EFS. They looked at the relationship between BRCA mutation, here those with germline mutation in the middle compared to wild type on the right and all patients on the left, and the relationship between having a PathCR and having good event-free survival is the same in the BRCA mutation carriers as those who are wild type. And so that suggests that one might interpret those results similarly for the two populations. They'd previously shown that being a BRCA mutation carrier didn't affect the result with regard to the improved pathological complete response for the addition of platinum and the lack of further improvement with the addition of veliparib. So the investigators now argue that in fact this result on EFS should be taken regardless of BRCA mutation status. Now, could you actually de-escalate therapy by selecting patients based on response to neoadjuvant treatment just with a PARP inhibitor if they've got a BRCA mutation? So this proof of concept was first looked at in a study by Jennifer Litton and colleagues with 6 months of talazoparib and then surgery, and looking at the rates of pathological complete response or that with minimal residual disease. And more than 50% of patients selected by BRCA mutation had pathological complete response with just 6 months of single agent talazoparib. And so the study kind of went on and tested, in a larger group in NeoTALA, just reported at ASCO, the experience in, as I say, a larger group of patients. And again, about 50% of patients achieving pathological complete response, suggesting it might be possible in those patients to then de-escalate further use of chemotherapy. And I think this is an excellent question, but it still remains a question. I don't think yet ready for prime time, but may certainly influence trial designs to look at whether selection based on pathological complete response could lead to de-escalation of chemotherapy for some. Clearly some still with significant residual disease and still requiring chemotherapy and improvement in the treatment approaches. Now, the German breast group have looked at whether you could take a standard regimen containing platinum and taxanes in neoadjuvant therapy, select patients based on homologous recombination deficiency, and then swap out the platinum and replace it with olaparib ahead of EC. And they targeted pathological complete response for the endpoint. And the study did not show that there was an improvement with the use of olaparib instead of the platinum in that regimen. But there was certainly significant activity you can see here with taking platinum out and replacing with olaparib. And that activity came at a lesser cost in terms of toxicity. So interesting question about whether you could de-escalate the adverse effects of these regimens by replacing platinum with a PARP inhibitor. Also, it certainly seems that in ER-positive disease, there are effects of olaparib. So certainly no suggestion in this study that effects of olaparib in comparison to platinum here are just restricted to patients with ER-negative disease. And I think that's important that we note that ER positivity is not a group that don't have activity for olaparib. And the trials that are so it's an important thing that we now try and understand and categorize who develops recurrence despite PARP inhibitors, and how do we understand platinum and PARP inhibitor resistant forms of the disease and improve outcomes. Now, Olympia will allow us to study the recurrences that are occurring despite olaparib in this setting, and we have an intensive translational science program in Olympia to try and address this. But we can also do exploratory analyses on trials like GEPAR-OLA to study the residual disease after neoadjuvant chemotherapy with platinum or with olaparib, and try and understand what clones are still surviving this and what are the resistance mechanisms that overlap or are distinct between these types of drug, and how do they intersect with data we get from our CRISPR-Cas9 resistance screen data in isogenic systems in the lab. Could we extend this principle to other genes, other mutations associated with breast cancer, PALB2? Well, certainly there's data from studies like Beyond BRCA that suggest activity in germline PALB2 mutation carriers for PARP inhibitors like talazoparib, and very recently data from the TBCRC 048 study published by Nadine Tung and colleagues, again showing significant activity in the advanced disease setting for those with germline PALB2 mutations, breast cancer treated with olaparib. The American College of Medical Genetics and Genomics have suggested that we really should consider PALB2 to be very like BRCA1 and 2 when considering therapeutic implications of germline genetic testing. I think we have to, think carefully about what this means in the adjuvant therapy context, but the idea that one would try to run a trial of Olympia proportions to test this principle in a group with a lower prevalence in the community than BRCA1 and 2 is very challenging. And I think trying to think what proof one needs from trials to extend this principle to PALB2 is something we really do need to think about because the rationale is strong. Whether to integrate and how to integrate PARP inhibitors with anti-PD-1 checkpoint inhibitors is really something we need to address now based on the data we've seen. I just wanted to point out, when you look at the results of those who don't achieve pathological complete response despite checkpoint inhibitors, then this is a population of patients who the guidance at the moment, if they've got a BRCA mutation, is that they should potentially be considered for olaparib. And so how are we going to combine this with the fact that they may also be recommended pembrolizumab? Now, there is a rationale for the combination in any case, based on PARP inhibition in BRCA deficiency stimulating an immune response that could be edited by checkpoint ligands. And so you can make a rationale for the combination. It would appear that they are tolerable combinations, but the efficacy of the combination of the synergy is really unknown and unproven. There are tests of pembrolizumab and olaparib in metastatic triple-negative disease ongoing, and as I say, the combinations of olaparib and pembrolizumab appear tolerable in other diseases. And the final question, which we've not got time to address, is can we extend some of the principles that have been proven in genetic forms of HR-defective early breast cancer to the epigenetic forms? Now, this may be more challenging in advanced disease because that methylation is lost, but it is probably lost less in early disease. And so designs are underway to test this. So in conclusion, current regulatory approvals for PARP inhibitors are only in advanced germline BRCA mutated breast cancer. The Olympia trial tested olaparib as a follow-up therapy, adjuvant therapy in those with germline mutations, and showed highly statistically significant effects on IDFS and DDFS, and new guidelines support its use in those eligible who would have been eligible for the Olympia trial, but there is no regulatory approval at present, I must point out. Promising data suggest trials testing potent PARP inhibitors as single agents or as more tolerable platinum substitutes in neoadjuvant regimens in HR-deficient early disease, but I don't think this is ready for prime time yet. It's a clinical trial question. There is important work needed, mapping and targeting distinct forms of PARP inhibitor resistance in early breast cancer, and are underway, and this will also influence therapy in the metastatic setting. And anti-PD-1 therapy is here for the same group of patients that we might be considering olaparib for, and with a preclinical rationale for the combination and evidence that there are tolerable combinations, but the efficacy of the combination, the additional efficacies are unknown, and there is significant financial toxicity with the combination. And trials exploring the targeting of epigenetic BRCA-ness in early disease are rational and are in development. And I'd like to thank wonderful group that came together, and the patients and their families who took part in the partnership that is Olympia, and to the labs that worked hard to develop the concept that we were able to take to the clinic and test, we hope, with clinical impact now, and our funders. We also thank those in the lab continuing to work on PARP inhibitor resistance and sensitivity, and a wide collaborative network. Please contact us if you'd like to join the group with Chris Lord and myself. Thank you very much for listening to me.